So this has been a very active week in many ways. Yeah, we did a former podcast about your active week in terms of personal and professional interactions you've been having in the past week. And Zach, you lead an interesting life for God, given that you live in a stress-free community, least stressful community in the United States, according to a list that I was sent. You're still getting out there and doing a lot of exciting things, both in your own personal life and professionally. So kudos to you. I want to talk. We're going to a different level now. This was a big week in news. They've come up with a figure for how many people died of, they call it overdoses last year. 93,000 Americans died from drug overdoses, up nearly 30% from 2019. Um, I'm just going to read some lines. This is a staggering loss of human life, Brown University's Brandon Marshall told the Associated Press. The big picture, the shocking figures reflect the proliferation of fentanyl and the pandemic's toll on the opioid crisis, reports Axios' Arundhati. However, deaths from methamphetamine and cocaine also rose, which are not opioids. They're opposite of they're not painkillers. And then the bottom line is this: more than 900,000 people have died of overdoses since the U.S. drug epidemic began in about 1999. We went into COVID with this issue already existing. The acting director of the Office of National Drug Control Policy, Virginia LaBelle, told the New York Times, but we were seeing an increase before that. And this gets back to a theme that we're always talking about. What is it that we're doing so brilliantly, either in terms of the disease model, which has been around forever and promoted by the Office of National Drug Control Policy, past directors, and the modern drug policy reform movement, and yet drug deaths keep accelerating at an incredible rate. So the second news item that came out, a new study by Julia Donahue, the University of Pittsburgh Graduate School of Public Health, and her colleagues, we talk about medication-assisted treatment, and you're going to be interviewing one of our great sources, and Maya Salovitz. She wants it to be called simply medicine, and that's now, while we weren't watching, that's now happened. Medication-assisted treatment has now become medicine for opioid use disorder, and they measured how much that has been dispersed. Opioid use disorder treatment increased in Medicaid recipients from 2014 to 2018. Data from 11 different state programs show. The proportion of people with opioid use disorder who received buprenorphine, methadone, or naltrexone increased from 48% to 57% across that period. So one version of what's happening in America is, we're too wedded to the old abstinence approach. We need harm reduction, which means that we should give people other medications to address their addictions. And you and I recognize a role for that, but that quickly segues into, well, we have medications for dealing with and treating addiction. And that's where we're at now. That's what MOUD is now being presented at. And this study stopped in 2018, but it's impossible that those figures, those numbers, from 48% to 57% have done anything but increase since then. And so the two news items of the week that we have to confront are 93,000 deaths, a quadrupling or a quintupling of deaths since the turn of the century in 2000, 900,000 people dead, and yet we're doing more by far of what is being claimed by drug policy reformers to be the best thing that we can do for them, which is to provide this array of medications, substitute, or now naltrexone is meant to supposedly suppress the urge for narcotics. That's never been shown. I mean, methadone has been shown to decline deaths in the short term. On the harm reduction front, I want to read something from how we deal with this and how I deal with it. Filter did an article about harm reduction. Harm reduction at its core is about challenging stigma. It means respecting people for their whole selves and lived experiences while avoiding judgment. It prioritizes people whose identities are marginalized by society and who are therefore especially vulnerable. So they're talking about harm reduction existentially. They're not saying, well, harm reduction means using, but they don't mention MAT at all in this article. Harm reduction, quote, is more than just a package of interventions, said Judy Chang, executive director of International Network of People Who Use Drugs. Harm reduction is linked to social justice and human rights. Now, have you become involved with an organization like that, Zach? Not that International Network of People Who Use Drugs. Are you involved with a group of drug users? Can you just mention that experience or that operation?
Well, yeah, there are people who use primarily illicit drugs who are trying to figure out how they can have a voice at the table to get the things that they want. I mean, they'd like to pursue a good life track and they'd like to continue using drugs for now. And some of the ways that they've been told that they can do those things, okay, not some of the ways. The one way they've been told that they can do these things is to enter some sort of treatment for their addiction. Some people say, I'm not addicted, or at least if I have an addiction, like the way that maybe you and I describe it, is the drugs aren't the thing. It's like the Carl Hart thing. Drugs aren't the problem. Or sometimes people say, great, that sign me up. And they're supposedly getting medications, no questions asked, or, some sort of drug substitution, no questions asked, but that's not really the way it works. You got to line up. Sometimes you miss it. Sometimes you don't. You have to have a urine analysis that meets people's requirements. And so this is a group of people who's saying, why the hell can't we just make a realistic ask for the things that we need?
And so this version of harm reduction is linked to social justice and human rights. They're human beings who are using drugs as their way of getting through life. Maybe there's a better way for them. Maybe they're headed in that direction. But they're a human being right now, and that's how they need to be treated. But this article in Filter, because harm reduction is often associated with specific public health policies, such as providing resources like sterile syringes and naloxone, establishing safe spaces for drug use, or increasing access to safer alternatives from methadone to nicotine vapes, public discourse around it often loses sight of the bigger philosophical vision, which is this article in Filter is saying what we're saying, that focusing on, methadone is harm reduction, or naltrexone is harm reduction, they're not defining it in the larger terms, bigger philosophical vision. Drug policy reform advocates' messaging has sometimes unwittingly contributed to this. We've been saying that by defining harm reduction as, methadone or buprenorphine. And for example, phrases like treatment instead of incarceration, which we talk about in terms of the Oregon initiative. People say, we're going to give people treatment instead of putting them in jail, may be effective in getting public officials and media to buy into certain programs, but it also sits uncomfortably with deeper aspects of harm reduction. Now, I bolded this. I think people understand the immediate need for harm reduction. I'm not always clear if people get the underlying tenets of self-determination and choice. Wow. And that was Cassandra Frederick, who's the executive director of the Drug Policy Alliance. That's a heavy, brilliant statement, She's saying, well, methadone, of course, that's important, but that's not, and we just were talking about it in terms of the drug users union. The issue is really the human being having the ability to exercise agency about their own life, that they're in charge of their own life and trying to make the best path for themselves. They're not trying to hurt themselves. They don't want to do something that they don't want to die for sure. They don't want to necessarily be addicted or not addicted. They want to have a freedom to choose to have the best life they can. And so Cassandra Frederick says quote, some of our arguments and some of the ways that we win politically are about, we get syringes because they help with bloodborne diseases. We have syringe exchanges so there won't be syringes in our park. We need safer consumption spaces. But the driving reason why we do these things is because we're trying to create a world that recognizes that people use drugs. And so my note is, I did give a talk to DPA. I don't remember Cassandra being there, but I'm going to describe what I told them. And here I'm going to my memoir, Harm Reduction, a scientific life on the edge, my lonely quest to change how we see addiction. And I, in one chapter, say we need a fundamentally new way of thinking. And there are 5 concepts that I wanted to redefine. Number 1 is harm reduction. Drug reformers dealing with drugs, drug problems, and addiction without requiring users to abstain. That's the standard definition. My definition, concentrating on the person's ability to manage their life regardless of their drug use profile. It almost sounds as though Cassandra was listening to my little talk to DPA. When she seems to be almost answering me. I redefine 5 concepts. The medical approach to addiction. Reformers' medical approaches are objective, humane ways of treating people with drug problems. My read. The disease view embedded in American thinking since temperance times teaches people that addiction and thus drug use is beyond the individual's and the community's ability to control. This current policy reform meme is exact opposite of the message drug policy reform should be conveying. MAT, reformers, medication-assisted treatment is a modern miracle that cures addiction, favored by Nora Volkow and NIDA, Ethan Nadelman and DPA, the former head of DPA and drug courts. My read, MAT is the latest magical elixir for addiction, a false solution that obviates the need to create an equitable society and fulfill people who are contented with their lives. Meanwhile, the evidence-based argument is that reformers show that MAT has been demonstrated to be effective. The problem is, if it's so effective and it's spreading, why are more people dying all the time in an accelerated way almost? And my answer to that is MAT is being sold, and now MOUD, as being an answer for addiction in a way that deprives people of their agency, so that people are being convinced that this is the only way they have to go, and that the treatment is the solution for their lives. And that's the worst possible message. So we need to think about drugs and addiction in a fundamentally new way. And here's how I propose doing that. I gave 10 steps to the DPA. Don't think in terms of addicts, alcoholics, and treatable diseases. Don't define the drug universe in that fashion. 2, regard addiction as a negative life state and a way of relating to the world. 3, strengthen non-disease-based communities, which you and I talked about in our other podcast. These are communities that aren't about AA, or I'm going to a community of people that consists solely of people who are addicted or alcoholic. 4, enhance people's purpose and connection, make their lives worth living. 5, address people's basic needs, health, home, family, work, life skills. 6, I put this in italics, foster people's belief that they can control their lives, support their agency. 7, support the choice to use or not and mindful use of all drugs and alcohol. 8, assist people who use drugs and who drink to do so safely and healthily. 9, cease not only criminalizing drug use, but diseasifying and what's the word when we talk about what we're doing with drugs in the larger society is that we're demonizing drug use. So cease criminalizing and demonizing drug use and even drinking alcohol. And finally, again in italics, regard drug use and drinking alcohol as normal human experiences.
At number 9 there, it's like, put it in clear terms, that we think that we're doing a service by saying, well, let's not criminalize drug use. But what we are really saying is, that's all right that you use drugs. We all make mistakes, kind of a thing. And you're saying, let's clear that all make mistakes thing. Let's talk about drug use in a more natural way.
It's a normal part of life. And of course, Carl Hart's going that way. It's normalizing drug use. So harm reduction is not a new concept of dealing with the disease. It's not saying, well, we got to fight the idea that you have to abstain from everything and we've got drugs to give you to overcome addiction. And I'm going back to what Cassandra Frederick said. It's a way of viewing the entire human being and how they're living in the world and how they're succeeding. And that involves looking at things from their perspective and accepting their human rights and their value as a human being and accepting their right to use drugs and alcohol as they see fit. And sometimes we as clinicians might think, well, they're not using it in the optimal way. It's not the best way. But that's not a choice that we have to make. And sometimes people in even the worst situations are actually making use of these things in the best way they can. Or in the alternative, what we have to say is we have to accept that that's their current resolution of their lives. And how can we make their lives better?
So there are people, this filter article saying, and DPA is owning the fact that it's a tough landscape out there. And so some of the worst reactions to people using drugs or becoming addicted, you want to improve on. And sometimes people improve in ways, well, only because they can get funding to do it. And it seems like the most saleable and easily accessible, broadcastable way. And when they do that, there are people whose whole careers are wrapped up in trying to reinforce whatever strategy it is that maybe cut corners and has eventually lost sight of the fundamentals of why they're in the work in the first place. And it sounds like they're sort of putting their head up and saying, we should look inward and think about how we're doing this now. Are you optimistic that that's what is being said here?
I was amazed by the article. It sounded like what I thought.
And you're saying, if you're getting to this point now, it's almost like you're doing harm reduction with them. You're saying, if you're getting this thought process now, let me return to the 10 steps that I laid out to keep focus.
And I'm, proudly wondering, I did talk to DPA. I did deliver those 10 steps to them. And did I have some kind of an impact, or our podcast and you and I talking in this vein actually feeding back in some way to DPA? After Ethan retired, I guess that's about 3 years ago now, they brought in a very distinguished woman who had a Latin American expertise, and she was very familiar with drug wars and interdiction overseas, but she didn't have a natural feeling for these issues of disease and harm reduction.
Right.
And Ethan suggested she have a lunch very early on in her tenure, and we met and we talked about these things. She sort of said, well, I don't know about those things. So I have no theory about whether drug addiction is a disease or not. And so now they've gone to a woman who was already, she was employed already at DBA. And that replacement for Ethan retired or left for another job after 2 years for a variety of reasons. And then they brought Cassandra Frederic was brought in. She was already there. I knew Cassandra. I know Cassandra. And it's just marvelous the degree to which she understands these internal issues and that she's turning to incorporate them within the DPA, which I've been somewhat critical of them for not doing previously. And so I just, I'm happy. I'm happy that's the way they're going. I wonder if I'm having you and I perhaps are having a sub rosa influence. I already have an award from the Drug Policy Alliance. In 1994, I received a career scholarship award, and 1994 is now more than 27 years ago, I think.
Wow.
So, I don't think I'm going to get it again. I'm just hoping they don't take it away from me, that they chisel my name off that plaque, What happened in 1994? I don't know. Somebody dropped some acid on that part of the plaque. So I could view this as a radical, might be strong a word, but a positive development. It's certainly in keeping with the way you and I think. And I'm wondering if, once again, I've had a sub-rose impact on the whole field. So I want to just, one other news item plucked from the New York Times. It wasn't a happy story in the New York Times. It was a story about how Venice, I don't know, is a famous area in southern, in the LA suburb along the beach. And I know that area pretty well. I have two cousins actually, who live in Manhattan Beach, which is a couple of suburbs down. I've stayed there a number of times. And California has by far the most homeless people in the country. It's not a happy story in California. And that area is one of the least happy. And it takes the place of a man who's a physician named King, is his last name. And, he's some totally Southern California character. He's got long hair and a beard, and he surfs. He's a member of the community. He lives in Venice. And I think, I don't know how he gets paid. I guess I didn't figure that out from the article. He provides medical care to these large conclaves of people of homeless people. And then when maybe it's when he bought his home, it said something like, well, in 1996, you can get a 2,000 square foot home in Venice for $300,000. That's a lot of money, but now they're worth over $2 million. And meanwhile, Google and Facebook have offices nearby there. So now Venice is a place of millionaires and homeless people. And they're sort of like, what do you do about that? That's a little bit beyond our level of expertise. I mean, they keep trying to budget for it. And the conflict in Venice is there's a group of people who say, well, let's get rid of all these people. And then there's another group who says, well, is there some way to provide actual housing for these people? And into this environment, this doctor named King, who lives there, surfs there, he goes around every day to help people in homeless communities. They're not shelters, they're like street tent areas. And they describe his interaction with a man named Simpson. And he offers, can you come in? He has a van, King, and he's got nurses. And he says, well, can we give you some medical care? Can we, take some tests? Simpson hesitated, but soon he scrambled up into the van. As his blood was being drawn, he kept apologizing for, quote, wasting everyone's time. What's he saying about himself when he's saying, I'm wasting everybody's time by getting medical care, do you think? How would you translate that?
Well, that he's not worth the medical care, and that he's not just you're just keeping me alive for another minute, but I'm not going to get any better.
He explained that he had been homeless for 30 years. He's 64, and that his family banished him because of his alcoholism. I really shouldn't be alive, he told me. Simpson also said that he had gotten his first COVID vaccination the week before and showed me his card. King pulled up Simpson's record on his smartphone, from which he accesses patient records. The clinic had treated Simpson for a wound in his hand 2 years earlier. His blood pressure was lower now than back then, but still a little higher than ideal. So he's living.
He's done harm reduction for himself. He's gotten a vaccine, so he obviously doesn't want to get coronavirus.
That's a positive.
He's taking care of his blood pressure. It's better.
Man. For God's sake, he's improved. The doctor asked whether Simpson wanted to move into a temporary bridge shelter a couple of blocks away. I honestly don't. I thought bridge shelter, does that mean it's under a bridge? But I think it means it's transition.
Okay, that's what I thought at first too. So don't be embarrassed.
He does get a bed, access to showers, and 3 meals a day. Now this is where harm reduction brings me to tears. I still have a quart of vodka to drink, Simpson said. But I'm the friendliest drunk there is. And King said, God bless King. I don't know if he reached filter or what. He said, bring it with you. That's harm reduction. He's not saying, oh, God, you can't drink in the shelter. That's called wet housing. Then he asked the social workers, his team, to help find him a bed for Simpson to move into that bed. That's the harm reduction that Cassandra Frederique was describing. This is a human being. Seems like a nice guy. He's, not in an ideal place with regard to substances. Most of us would agree. He's lived to be 64 and his blood pressure is going down. He'll probably do a lot better if he actually has a place to live and shower and sleep and get a meal. That'll help his life in a way that conceivably could help him deal with his addiction, if you call his alcoholism an addiction. And so I just wanted to end with that as an example of the kind of harm reduction that, I think they're outlining in the filter article, and that's certainly consistent with the way that we talk about harm reduction.
There are ways in which this person's improving already and showing signs that he wants to continue to improve. You could think about him being offered some sort of help that says, we'll help you, but you have to get this sorted out first. You can't be drinking while we're providing you help.
They can say, we'll help you with your alcoholism. King doesn't say that.
Right.
They want to help you with your life, a place to sleep, a shower, food. Let's start there. And let's not go to the, we're addiction thing.
Right.
It's all, and this King, I don't know where he's coming from. It's almost like he said, well, let's just forget about the addiction thing right now. Let's just look at you as a human being and what you need.
When life sorts itself out, addiction sorts itself out, because addiction is a response to life. And it sounds like this doctor isn't even thinking in those terms. He's just thinking life needs to sort itself out. First principles, that's it. Drinking, no drinking, whatever, but just to get you improved.
We're back to your 5-year-old nephew. It's like just thinking in purely human terms, throwing out anything that you've heard about addiction and just say, well, let's deal with the human concept, human being, and the human dilemma. And that's the best thing that we can do. And that's kind of our approach in the Life Process Program. It's kind of how we describe harm reduction. And it seems to be the way that, Cassandra Frederique described harm reduction in a way that I hadn't heard before from the harm reduction community. And it's also consistent with groups that you're working with, that some people call Drug Users Union, which is we're human beings who use drugs, but let's deal with us as human beings, and we'll deal with the drugs in the best possible way within that framework. And that's normalizing drug use without necessarily eliminating addiction, and that's harm reduction.
You almost don't want to be an addiction expert in this field. You could get in the way.
Your 5-year-old nephew and this Dr. King are two examples of that. Just two people just being human beings. So, all right, we've gone through a few heavy topics over the last week. Things are constantly changing. It seems that you and I are in a field that you don't retire in. The issues are constantly evolving. In some areas, they're worsening. I mean, more people are dying. We don't have the key to it yet, and we're offering a whole new slant on how to do it. That's our claim to fame. That's the purpose of our podcast.
Would you say you're doing harm reduction with respect to organizations like DPA, where you're kind of always there if they ever choose to return to you and your ideas?
I was invited to give a podcast to DPA, and I don't know. I know some people at DPA. I have some friends there, but I was sort of shocked. And then when I gave the podcast, Cassandra wasn't there, as far as I know. And they had at the time, she wasn't head. There was an acting head. He wasn't there, so far as I know. And so, I described what I spoke about, and I gave that list of 10 things, and I thought, is this like a drop in the bucket? I mean,
Yeah.
they got my slides, they kept them. It's an organizational resource. Nobody wrote me an email and said, well, the woman who invited me, Sheila, said, oh, thanks so much. We're old friends. Nobody said, oh, we're thinking this over. But in my lifetime, it's occurred to me that often happens.
Yeah.
Love and Addiction, I got no awards. But people all through my life have been saying, oh, you've really changed, the whole concept of addiction. Years later, Alan Marlatt told me that. Tom Horvath told me that. All kinds of people have told me that. So, yeah, I'm sort of the surreptitious harm reduction guy. I'm always throwing out ideas, and somehow they kind of get absorbed into the larger ice ball that's rolling down the hill. And I do have an impact that but it's like, it's like your poor gone cousin Josh. I just want to try and appreciate some of these things before my memorial service. My nightmare is that everybody will get up and say how great I was at my memorial service, and unfortunately I won't be around to hear it. I'm trying to move the ball, the script forward a little bit.
Okay, well, I certainly celebrate you for what it's worth.
I appreciate so much.
Dare I say that we're ending this in a sort of optimistic note, that people are sort of sorting things out and trying to head the right direction?
It's certainly a part of the parcel. I don't think all signs are positive, but we're in the picture. We're in the ballpark. We're in the mix.
Then I think we need to leave it at that. What do you say?
All right. Pleasure talking with you as always. Bye-bye, Zach.